Okay, should we go ahead and get started? Okay, great. So today I'm going to be talking about anti-GBM glomerulonephritis with extra thanks to Isa, who helped me get all the clinical information together. And I wanted to talk about anti-GBM because I think that the situation that we have in BC, it's a unique way to see a disease such as GBM that's not that common. So like in Chicago, we had 5 academic institutions with all of their subsidiary hospitals, both private as well as associated with universities. So even with about 1,000 cases a year that we would do for biopsies, we would only see 1 case of anti-GBM each year. So most clinicians would never see it. The fellows certainly never saw it. So I think we're in a unique situation that we see, at least on the pathology side, much more, as you'll see. So in general, anti-GBM isn't that common. It's about 15% of all diffusely crescentic glomerulonephritis. And the reported incidence is about somewhere around about a 1 in a million. It varies, again, because it's not that common, so the incidence also varies. So in BC, the projected current population is just over about 5 million. And looking back in our archives from 2008 to 2018, we have 69 biopsies that are top-lined as anti-GBM GNs. And it's not individual cases. Some patients are rebiopsied. There's some recurrences. But if we take all comers, where we top-line that there's abnormal anti-GBM staining without a firm diagnosis of anti-GBM GN, it's about 88 biopsies within a 10-year time frame. So we actually see a fair amount. And in terms of anti-GBM, so there's an equal incidence between men and women and a bimodal age of onset, usually peaking in the 3rd decade or the 6th and 7th decades. So anti-GBM is like the quintessential, at least for testing purposes, idea of diffusely crescentic GN, but really it encompasses three different entities. So there's the classic anti-GBM GN, which we'll talk about, posse-immune, which is the majority of the cases, and also immune complex GN, such as lupus or IgA. And all of these are differentiated by particularly the immunofluorescence microscopy findings, but also the light and EM findings. So in terms of crescent formation, so there's a couple different things that we talk about. One is the number of crescents. So diffusely crescentic means that there's greater than 50% of crescents. Focal is less than or equal to 50%. And we also talk about the nature of the crescents. So we talk about size and the activity, if they're all cellular or not, or if they're, as you see in anti-GBM, or if there's a mixture of activity and chronicity. So there's a combination of cellular, fibrocellular, and fibrous crescents. And so in anti-GBM, these are all diffuse, necrotizing, large, and they're all activity with essentially no chronicity. And so anti-GBM is a small vessel vasculitis. So it affects the glomerular and pulmonary capillaries in particular. It doesn't affect the arteries. So if there is necrotizing vasculitis, it usually implies that there's a concomitant ANCA. And what defines anti-GBM disease is the presence of circulating or deposited antibodies, and these are autoimmune antibodies to basement membranes. And so there's a couple of terms that get kicked around with anti-GBM. So first is Goodpasture syndrome, which is pulmonary renal syndrome caused by anti-GBM antibodies. Anti-GBM GN, which is renal involvement only, and I'm only going to be talking about renal involvement. And then rarely you can also get pulmonary hemorrhage only. And so in terms of classic anti-GBM disease, the classic presentation is a crescentic GN where you get a rapidly progressive glomerulonephritic presentation. That's about 80 to 90% of all cases. And there's variable frequency with pulmonary hemorrhage. It's been reported anywhere from 40 to 60%. And these can also occur with ANCA, which we're going to talk about, and can rarely recur in transplant. So usually recurrence is rare because it's a low rate, because usually they're only transplanted about 6 months after seronegativity. But there is the case of Alport anti-GBM GN post-transplant. And so with anti-GBM, there's a lot of environmental triggers that are thought to be involved, such as cigarette smoking, hydrocarbons, and some of the new monoclonal antibody treatments. There's also a genetic association where 80% of these patients have an in HLA-DR2, and there's also some seasonal variation as well. And in Chicago, our one case would always come in the spring, so right now is about the time of year where we would get our case. Like, we'd be excited, we'd get it, and then we'd never see it for the rest of the year. So I'm going to be talking about 4 different patients and kind of go over the spectrum of what we see in anti-GBM-GN. But first, we're talking about classic anti-GBM-GN, which I think is, straightforward, and it's what we all think about, and it's probably the easiest, and then we'll get weird. So, and also, if anyone has any updates or corrections or anything to add about these patients, please chime in. So this is the case of a 51-year-old man who is from Fort Nelson. So he had a history of mechanical aortic valve for his aortic stenosis and was on warfarin. And it was complicated by endocarditis with septic emboli in 2017, resulting in acute tubular injury in the setting of antibiotics for the endocarditis. Also developed a seizure disorder from the septic emboli, AFib, hypertension as well. And so he presented at Prince George Hospital in August of last year with acute tubular injury requiring dialysis with a creatinine of almost 800. And during the full workup, he was found to have a high anti-GBM antibody titer, which was above the upper limit of detection for the assay, so it was greater than 600, so who knows how high it actually was. But no incidence of pulmonary hemorrhage, but he was transferred to St. Paul's on dialysis, where he received a renal biopsy. And so I'm going to show the biopsy in a different order than usual, because anti-GBM is defined by the immunofluorescence microscopy findings, so we'll go over that first. So here, there's IgG, fibrinogen, and C3. So you can see the quintessential defining feature of anti-GBM-GN, which is strong linear deposition of IgG along the basement membranes. And here it's actually quite difficult to determine the basement membranes because it's so destructive to the glomerulus. But trust me, this is linear. And this was in every glomerulus. And also what's what we often see is an inversion between IgG and fibrinogen. So here is what's remaining of the glomerular tuft, but this is a very large and necrotizing crescent, which is where you can see the necrosis is staining here. As well, these cases will fix complement, and so here is the small bit of tuft staining for C3, and these are also polyclonal, where they stain for kappa and lambda light chains, and this was all above the background of albumin. And so this is the quintessential finding because of the nature of the glomerular basement membrane. So here you can see the GBM with the podocytes and the endothelial cells. And the GBM is made up of a meshwork of type 4 collagen, and each strand of type 4 collagen is made up of 3 alpha chains, alpha 3, alpha 4, and alpha 5. And these form this meshwork where they have an interaction of the non-collagenous domains. And normally these non-collagenous domains within the meshwork are buried and not exposed outside of the GBM. But whenever there's destruction or something like cigarette smoke, some sort of environmental trigger that damages these membranes, it then exposes what's usually a cryptic epitope. And in particular, it's the epitopes EA and EB on the alpha 3 chain that are usually sequestered, but under these conditions become available. And so after the genetic insult, especially in patients with genetic susceptibility, you get exposure of these epitopes that the body normally doesn't see. So then an IgG autoantibody develops to the alpha 3 NC1 region. And these are pathologic, and they're usually IgG1 and IgG3 subtypes. So in addition to the antibody being pathologic, it also then causes this inflammatory cascade where there's reactive T cells, it fixes complement, and also brings all of these inflammatory factors in to then lead to destruction of the glomerular basement membrane, which then leads to necrosis, cytokines, and then you get the development of cellular crescents. And so the result of that is what you see here. So this is a medium power image of the biopsy. And I don't have normal in comparison, but you can see that normally you have tubules that are back to back without anything in the interstitium, but you can see these tubules are widely spaced. There is numerous patches of interstitial inflammation. There are some red cell casts as well. And normal glomeruli, you can usually, even at low power, see the capillary loops, but that's not present here. And in fact, these are the areas. There's 2 glomeruli right here. And on higher power, this is on H&E, you can see that these are necrotizing, that there's some fibrinoid necrosis here, as well as these glomeruli are surrounded by interstitial inflammation. There's red cell casts, and even with the destructive nature, there is some formation occasionally of giant cells. And on PAS, it really highlights here the large cellular crescent. And the uninvolved areas, you can still, although the tuft is a bit collapsed, you can still see that there are patent capillary loops, that there's not a lot of hypercellularity. And in this glomerulus here, you can see that not only is this cellular crescent large, but it's very destructive, where here there's the destruction of Bowman's capsule with the crescent and the inflammation spilling out into the interstitium. And this is classically the type of findings that we see in classic anti-GBM. And here's the Jones, just to highlight the destruction further. It highlights Bowman's capsule here, where there's breaks in Bowman's capsule, as well as breaks in the glomerular basement membranes that you can see here, again, leading to these large necrotizing and destructive crescents. And so for classic anti-GBM, as I said, they present clinically with RPGN, with or without pulmonary involvement. And the main 2 features are that they're positive for anti-GBM antibodies, so circulating antibodies, and there's strong linear IgG GBM staining. And usually these are crescentic, as in this case, where there's diffuse crescent formation in greater than 50% of the glomeruli. And the uninvolved glomeruli are usually unremarkable, so there's no proliferative pattern. And in the case of this patient, this was diffusely crescentic and necrotizing anti-GBM GN, where there was strong linear IgG on immunofluorescence and 100% glomerular involvement. And unfortunately, he did have a post-biopsy bleed. And in terms of outcome, so anti-GBM is usually treated with a short, intense course of Plex, cyclophosphamide, and corticosteroids to stop the production of the antibody, as well as to aid with the resulting inflammatory outcome. And there are a few predictors of poor outcome. There's the severity of renal function and dialysis at presentation. As in this case, he presented on dialysis, and the percent of gloms involved by crescents, and in this case, 100%. So even though the findings are quite dramatic, there's usually a low incidence of recurrence, even though these are autoantibodies. And in one series, it was less than 3% of patients. And that's generally because even though it's an autoantibody, you do develop a suppressor T-cell response that can inhibit the response and establish tolerance to the exposed cryptic epitopes. And so this was one study looking at 123 patients and looking at dialysis dependence at presentation and then looking at outcomes. So you can see here that 69 out of 123 were presented being dialysis dependent, as was this patient. And of the outcomes, 63 of the 69 remain dialysis dependent. But those that are dialysis independent at presentation, out of 54, 36 had stable kidney function and were able to stay off dialysis. And so this patient received 28 cycles of Plex at St. Paul's with reduction to his antibody titers to less than 20, as well as oral cyclophosphamide, and went through a prednisone taper, but did not show renal recovery, again, presented with dialysis and 100% of gloms involved, and transitioned from HE to PD last winter. All right, are there any questions or comments about this one? Okay, so I think classic anti-GBM is very straightforward. It's what we all read about. But things get more difficult with atypical anti-GBM. And I think a lot of the difficulty with atypical anti-GBM is that a lot of these entities have the problem that they are defined and called by a defining feature on renal pathology, but it doesn't really take into account the various pathophysiologies. And I think that atypical anti-GBM can very easily become a wastebasket diagnosis for anything that's not classical. So we'll kind of try to weed through all of that. So this is a 53-year-old woman who importantly was a smoker and had a prior history of uterine cancer that was treated 8 years ago with surgery and radiation, complicated by recurrent small bowel obstructions. And so presented with acute kidney injury requiring dialysis last July. And so she's had this rising serum creatinine. I don't have the initial, but at the time of the second biopsy, it was around 200. And proteinuria of 9 grams a day with anasarca. So at the time, there was a concern for membranous, especially given her prior malignant history. And so on workup, there were normal complement levels. Her SPEP and UPEP were normal. ANCA was negative, and importantly, her anti-GBM antibody was negative. And so her first renal biopsy was in June of last year, and the second was in October. And so this is the immunofluorescence from the first biopsy. So here's the IgG. You can see that it is nodular. There was some mesangial expansion, and here's accentuation of the glomerular basement membranes. And there was mild to moderate deposition. You can see it is slightly above the tubular basement membrane staining. Kappa was equivalent to background tubular basement membrane staining, and lambda, again, was above tubular basement membrane staining. So it looked that there was linear IgG lambda staining. On doing the subtypes, it was found to be IgG4, which will be important for later. And this is the follow-up biopsy. And again, IgG, you can see it's again nodular, but here now it's very strong and above that of background. So this case is complicated because smoking will cause dull linear accentuation of the glomerular basement membranes for IgG as well as albumin. But in this case, the smoking is not contributing to it because first it's above albumin, and second, you can see that usually for smoking and diabetic nephropathy, you'll get dull linear staining for IgG in the glomerular basement membranes as well as the tubular basement membranes, but these are negative. And so this gets to the differential that we go through when we've got linear staining for IgG. So there's several different methods that this can happen. One's through antibody specificity. So this is what you see for anti-GBM disease, where you have these circulating anti-GBM antibodies that then bind to the NC region of alpha-3, though it can also be for the other regions, and gives a nice, strong linear IgG staining. Another is where you have monotypic light chains. And so this is, you get staining because of the physiochemical properties of the immunoglobulin. So for these light chains, they are quite sticky to the GBMs, but it's not just the GBMs, it's also the TBMs, the interstitium, the vessels. So if you have something like light chain deposition disease, you get staining of the monotypic light chain in every compartment. And also, another aspect of the physiochemical properties of the GBM, this is what happens in smoking as well as diabetic nephropathy, that you get this thickening of the glomerular basement membranes and alteration of the heparin proteoglycans, so it changes the charge of the glomerular basement membranes. So you get a loss of the negative charge. So you get nonspecific binding, and this is also not strong. That's why you get that dull linear staining. And additionally, this is for true linear staining. You can have pseudo-linear staining, where it's actually like a membranous, but the deposits are so fine and it's beyond the ability to distinguish them individually on immunofluorescence, so it appears to be linear, but it's not. And so this is her first biopsy at low power. So there's quite a bit of glomerular sclerosis, but also you can see that there is dilation of the tubules, there is some acute tubular injury, But even these tubules are not quite back-to-back. There is some separation with interstitial inflammation and edema. And again, it's very difficult to see the nice open capillary loops of normal glomeruli. And you can see that the glomeruli are actually not normal, that as was seen on immunofluorescence, there is accentuation of the tufts where it's almost nodular. And also here, oops, there is a moderately sized cellular crescent. And again, nodular with mesangial hypercellularity. It's not just mesangial matrix, but it's two cellular, as well as a large cellular crescent. And again, I think you can appreciate that it's too cellular. There's also some endocapillary hypercellularity, and in addition to the large cellular crescent, it's also necrotizing. And contrast that to this glomerulus here, which is showing some expansion of the mesangium, but then patent capillary loops. And then this was her follow-up biopsy. And again, there's some resolution to the interstitial inflammation. Like here, the tubules are nicely back-to-back. But again, the glomeruli are quite nodular. And again, there's focal endocapillary hypercellularity here, as well as here. And in the second biopsy, some showed nice nodularity. You can see the difference here where these are more true nodules where there's no mesangial hypercellularity. And on EM, so EM usually doesn't have a place in anti-GBM disease. It doesn't really give us any additional information because there's no deposits. But in this case, it's important to rule out other entities so that you can see there are no deposits, so it's not the pseudolinear in terms of membranous. And here's the mesangium. Even though there's mesangial hypercellularity, there's no deposits. There is thickening of the glomerular basement membranes, which could be secondary to her smoking history, which you see with smoking as well as diabetic nephropathy. But again, the staining on IgG doesn't fit that this is the only cause. And so to summarize the two biopsies, so on the first, there was diffuse proliferative post-immune glomerulonephritis, so there were no deposits on EM with focal crescents and necrosis. And there was also weak linear IgG lambda restricted GBM staining. On follow-up, there was focal proliferative and nodular post-immune GN with rare crescents. And now it had developed from a weak monoclonal to a strong linear polyclonal IgG GBM staining. So putting this all together in terms of the patient history and what was going on, it was most consistent with an atypical anti-GBM disease, importantly because she was persistently negative for anti-GBM antibody. So about anti-GBM antibody detection, because it's important in this case to understand exactly what's getting tested and what it means in terms of interpretation. So in the first case, there was high titer anti-GBM antibody, but not in this case. And some of it is thought to be due to how the antibody is detected. So anti-GBM is detected by an enzyme immune assay or bead immunofluorescence assays, and these have limitations. Western blot is more sensitive, but it's not the standard test. And so these enzyme assays have high sensitivity and specificity, specifically for the EA-EB epitopes. And so they may fail to detect other conformational epitopes, other cryptic epitopes. In particular, importantly for this case, they don't detect antibodies to IgG4. Also, there's been reported antibodies to IgA and IgM, which this test does not pick up. And they also do not pick up epitopes on alpha-4, alpha-5. So you could have a circulating antibody. It could be a true anti-GBM, but it looks negative just because of limitations of the test. And so, yeah, negative. So for atypical anti-GBM GN, these patients, there isn't as much in the literature, but at least what's published, they present with mild renal insufficiency, hematuria, and proteinuria, as opposed to the RPGN like with classic, and generally no pulmonary involvement. And importantly, they're negative for the anti-GBM antibodies. So like I mentioned before, it could be because these patients have epitopes other than EA and EB or other subtypes, other subclasses like the IgG4. But it could also be that they have a low affinity antibody. So it's below the limit of detection for the test. Or it could be that there's a high avidity for the glomerular basement membranes. So they have the typical antibody. It's all being sopped up by the kidney and it's all being deposited in the GBM. So there's a lot that could be happening in terms of pathophysiology that it's complicated and we just don't know. But importantly, there's strong linear IgG-GBM staining. And again, that's the definitive characteristic. And also differently, they show endocapillary proliferative, mesangial proliferative, or membranous proliferative pattern in the uninvolved glomeruli, again, differing from classic, which are unremarkable. And so a lot of the confusion, I think, comes from the largest series published, which came out of Mayo, where it's 20 cases, and 9 of these had endocapillary proliferation, 6 had mesangial proliferation, 3 with an MPGN type pattern, and 2 with no proliferation, but FSGS, 1 with a tip lesion and 1 NOS. And of these 20 cases, there were focal crescents only in 8, majority didn't have, and there was only rare fibrinoid necrosis. And of these 20 cases, 17 showed linear IgG, 2 with IgM and 1 with IgA. So again, likely not picked up by traditional testing. But some of these were light chain restricted. And so it's unclear if the light chain restriction is or is not related to an anti-GBM disease or is more closely related to a monoclonal deposition disease. And most of these were IgG1 or IgG4, again, which would not be picked up by traditional testing. And only about half fixed complement. And again, that makes sense because with the IgG4 would not necessarily fix complement. And so with these 20 cases, they presented with hematuria and proteinuria, but low serum creatinine, and none of them presented on dialysis, and none with pulmonary involvement. And they had good one-year patient and renal survival rates. And presumably, atypical anti-GBM gives better outcomes than classic anti-GBM. But from that other study that I showed, even with classic anti-GBM, if you present not on dialysis with milder disease, lower serum creatinine, fewer crescents involved, you tend to do better. And so for this patient, received oral cyclophosphamide until early this year, and steroids, but those were stopped. No Plex in this case, as it was felt to be mild. Still dialysis dependent, but serum creatinine decreasing. Any comments about this case or questions? All right, so now dual positivity. So this was a patient, 72-year-old woman with a history of CREST, polymyalgia rheumatica with positive ANA and anticentromere antibodies, as well as iron deficiency anemia, bronchiectasis, and some other issues, and had previously been on prednisone for polymyalgia rheumatica and CREST. And so she presented to RCH last September with acute kidney injury with a serum creatinine that went from 80 to over 200 over the course of 2 weeks, as well as some low-grade proteinuria with an ACR of 61, and hematuria with a mildly positive ANA. And what makes this case interesting is that dual positivity, but had a clear positive MPO ANCA with a titer of 47, and positive anti-GBM antibody, but a weakly positive titer. So where positive is greater than 8 and the titer was 11. And so here's the immunofluorescence. And again, IgG, you can see very nice, clear, linear, strong linear staining for IgG. And for fibrinogen, showed focal necrosis. So unlike the classic anti-GBM, which showed the entire Bowman space filled with necrosis, this is focal. And those focal findings were reflective in the biopsy. So you can see the tubules, again, are pushed apart. There's interstitial inflammation as well as some tubulitis. There were numerous red cell casts. Most of the glomeruli were completely uninvolved. You can see here, this one is normal with no mesangial hypercellularity, no endocapillary hypercellularity. You can clearly see the capillary loops. but this glomerulus here is involved by a large cellular crescent. Again, the uninvolved aspects well preserved with no proliferation. And again, a normal glomerulus, and here a glomerulus with focal necrosis and a small cellular crescent. And so this case showed focally crescent forming and necrotizing glomerulonephritis. So 4 out of 15 glomeruli, so 27%, had cellular crescents with or without necrosis. In this particular case, there were no fibrocellular or fibrous crescents. It's probably early disease, but there was strong linear IgG-GBM staining. So this is a case where there's positive ANCA as well as anti-GBM antibodies. And the dual positivity of ANCA and anti-GBM occur at a rate together that's higher than if it were just due to chance alone. And about 10% of patients with ANCA do have positive anti-GBMs, and almost half of patients with anti-GBM also have positive ANCAs, and these are usually MPO, as in this case. And again, strong linear GBM staining. And so for these dual positivity cases, they can clinically resemble anti-GBM at presentation with a similar dialysis dependence at presentation, as well as plus minus lung involvement, but generally have a longer prodrome, more like ANCA. And the glomerular histology usually resembles ANCA more, where there's a variable activity and chronicity. It's not like the classic where they're all active, but there's focal crescent formation and usually variability with cellular, fibrocellular, and fibrous crescents, although in this case it was just focal cellular. And it's usually more chronic injury similar to ANCA. And importantly, these cases of dual positivity are more likely to relapse. And so here with one study of dual positivity, you can see here are the anti-GBM cases with number of patients that are relapse-free, 100%, and those with ANCA and those that are double positive, where they're quite similar compared to anti-GBM. And also time to end-stage renal disease with ANCA, dual positivity, and anti-GBM. And so the association between ANCA and anti-GBM isn't clear, as I think with a lot of things with anti-GBM. Some studies suggest that ANCA disease predates the anti-GBM, so which makes the most sense to me, where the ANCA can disrupt the structure of the glomerular basement membrane, which then leads to exposure of these epitopes. And then you start out with the ANCA, you now have exposure of the epitopes in a genetically susceptible patient, and so now you develop the autoantibodies to the cryptic epitopes. Or ANCA can develop because of these extracellular neutrophil traps, which can also be formed in anti-GBM disease. And so it predisposes development, particularly of anti-MPO antibodies in these cases. And both ANCA and anti-GBM do have an association with HLA genes. So it's probably additional injury in genetically susceptible patients. And so for this patient, given the serology and biopsy findings, it was felt to be most in keeping with ANCA with a secondary anti-GBM or an early anti-GBM. And so in terms of management, she received 7 days of Plex at VGH, oral cyclophosphamide, as well as prednisone. And her most recent creatinine was 112, so it had come down recently this month. Okay. Any questions about this case or dual positivity? Okay. So now anti-GBM GN in a transplant patient. So I think a lot of people are aware of this case and kind of what happened. But I think in terms of, it's interesting in terms of the pathophysiology and the overall discussion about anti-GBM as well as antibody testing. So this was an 18-year-old female who was a Syrian refugee who lived in a camp in Turkey for 3 years prior to coming to Canada in 2016. And she had end-stage kidney disease of unknown cause, though later Alport syndrome was suggested given her family history of renal disease as well as hearing loss. So she had a live donor transplant from her mother at age 15, but unfortunately lost the graft, where she remained on hemodialysis, and when she arrived, she was not on immunosuppression. So she was started on dialysis at VGH after moving to Canada and received a transplant at VGH in August of 2017. But the graft was complicated by delayed graft function and was dialysis dependent after. And importantly, upon workup, her anti-GBM titer was quite high at basically 128. And so for comparison, this is the implant biopsy of the transplant that she received here in 2017. So you can see at low power, it's essentially normal, where we've got all the tubules nicely back to back. There's no interstitial inflammation, no interstitial edema. There are no red cell casts. And unlike all the other cases I've shown previously, you can nicely see all the patent glomeruli, even at low power. And looking at higher power again, you can see the tubules are nicely back to back, and these glomeruli are normal. There's no mesangial expansion, hypercellularity, endocapillary hypercellularity, nothing in Bowman space, just completely normal. And so now this is her immunofluorescence, and all of her subsequent biopsies essentially showed the same. So this is from the last case because it illustrates it the nicest, but all of them showed the same, where you can see for IgG, strong linear IgG staining, fibrinogen, large necrotizing cellular crescent, as well as strong linear staining for C3, just like classic anti-GBM-GN. And so going through all of her biopsies, so she had several post-transplant. This was 6 days post-transplant with delayed graft function. You can see generally the tubules are still back-to-back, though there is some acute tubular injury, there are some red cell casts, but you can see that the glomeruli are not as normal as in the previous implant biopsy. And looking at higher power on a few, you can see here, there's focal necrosis here, as well as some here, as well as some focal necrosis here. You can see there were a large number of red cell casts, interstitial inflammation, as well as some extravasation into the interstitium. And I don't have her second biopsy because her second and her third biopsy, which is the third one being 2 months post-transplant, are essentially the same. You can see at low power that there are still persistently a lot of red blood cell casts, continued acute tubular injury, as well as interstitial inflammation, edema, and again, all of these glomeruli are not showing normal findings even at low power. And here at close-up, you can see that there's a large cellular crescent. And so to summarize, her 0-hour biopsy was unremarkable. The 6-day biopsy post-transplant showed focal active anti-GBM-GN. So there were 4 cellular crescents, 2 with segmental necrosis, so about a third of the gloms were involved, with moderate segmental IgG-GBM staining. 19 days post-transplant, again, 95% of the gloms showed cellular crescents, now with strong linear IgG staining, and 2 months, 80% of the gloms, now with some chronic findings where there were cellular as well as some fibrocellular crescents, but still diffusely active. And so anti-GBM in transplant can be associated with Alport syndrome. And the findings are similar to classic anti-GBM disease, where there's strong linear IgG staining, large crescent formation, they're all necrotizing, frequent red blood cell casts, and diffuse interstitial inflammation and edema. And this usually happens soon after transplant, as was the case here. And so the pathophysiology for anti-GBM in the context of Alport and transplant is interesting because it shows classic anti-GBM findings, but the pathophysiology is different. So usually, so in the case of Alport, you've got defects in the type 4 collagen, and you've got normal alpha-3, alpha-4, alpha-5 present in the graft, but not in the native GBM. And so as opposed to classic anti-GBM, which is an autoantibody, this is an alloantibody, where it's an antibody to the graft. And interestingly, though, it only occurs in some Alport patients post-transplant. In the studies I showed, it was about 3 to 5% can develop anti-GBM-GN. About 10% can develop antibodies, but they're not necessarily pathogenic. And it's because of defects, and it's even though there are lots of different genetic mutations and abnormalities that can occur in Alport, usually those that result in anti-GBM are defects that completely prevent normal assembly of the type 4 collagen. So it would be complete loss of the alpha 5. And so, as I said, these are not the same cryptogenic epitopes as in native. So because that it's usually there are defects in alpha 5, especially in X-linked Alport, these are antibodies to the alpha 5 NC region rather than alpha 3. And again, not all alloantibodies are pathologic. And and it makes sense, and that's why I think this case is interesting, that X-linked females are usually at low risk because they do have some expression of the normal alpha 5. And this case, I think, is also interesting because alpha 5 usually is not detected in the usual way, in the usual testing for anti-GBM GN. In the bead assays, that detects alpha 3, but they have antibodies to alpha 5. So it could be that, in this case, she did have positive staining, that it's an antibody to alpha 5, resulting in some epitope spreading, resulting in antibodies to anti-alpha 3. And so a few small studies, 80 to 90% of grafts with established anti-GBM failed, as did hers. And patients who have lost a graft to anti-GBM are at high risk for recurrence. And again, although it's not known, but the cause of the loss of her first graft, it's likely the same. And so she was treated with, again, Plex, cyclophosphamide, and steroids, eventually switched to rituximab in September of 2017, and remained dialysis dependent with no recovery. And it resulted in loss with allograft nephrectomy, and she's unlikely to be retransplanted. So are there any questions, comments? Or just in general, as these are my references, and so that's what I've got. So any questions?
Hey, Malin, it's Sean.
Hey.
Can I ask you, what's your opinion on the role of complement in anti-GBM disease? So certainly you mentioned BCC3. Certain studies have looked at the IgG subtypes in different disease severity of anti-GBM, and certainly it's not necessarily consistently demonstrated that IgG1 or IgG3 dominate patients who have more severe disease. Lots of patients can have IgG4 subtypes, and yet that's not necessarily thought to at least activate complement through the classic pathway. On the biopsies, do you see, do you think complement is the effector mechanism of the antibody in anti-GBM, or is it a secondary phenomenon? And do you see C1q or C4d staining? If you look for it, that would argue a classic complement pathway activation through IgG?
So I'm not sure if it's the driving force or not. For sure, I think it's contributing to it. So of the 4 cases, the first classic anti-GBM and then the last case of the occurrence in the transplant, those both had strong C3 staining and showed the worst involvement of the glomeruli as well as the tubulointerstitium. The second case of the atypical, as well as the dual positivity case, did not fix complement. So there was no C3 staining and there was no C1q staining. None of them showed C1q. We only recently have C4d for immunofluorescence, so it hasn't been done, and I'm not really aware about C4d. And in that atypical case, it was IgG1. We normally don't look at subtypes, so I'm not really sure if the complement is driving the pathophysiology, but for sure I think it's at least contributing to it, because my understanding is that those cases that do fix complement do have more severe pathology and more severe renal dysfunction. But the extent of which subtype is which IgG subtype is involved, I'm not sure, because IgG4 is thought to not fix complement, but then, we see complement deposition in membranous that's typically IgG4, so I really don't know.
Yeah, I guess I was wondering, if we don't see C1q, is the complement just activation of the alternate pathway or the mannose-binding lectin pathway as a result of just tissue damage, as opposed to the primary effector mechanism where you have an IgG antibody that is fixing the classic pathway of complement. Because, certainly IgG4 can activate the lectin pathway, which is what we think is going on in membranous, but it's just not as strong an activator through the classic pathway as IgG1. So it's just, I'm not really familiar with what we see at C1q staining at all or ever.
No, we very rarely see C1q staining. It's occasionally we'll see it in things like membranous, but very rarely in other entities. Usually C1q, as if we do see it, it makes us think of more an autoimmune etiology. Like we always automatically think of lupus than anything else. And I don't know if we have really anything to look for the alternative or lectin pathways, because C4D is also gets deposited as a result of the classic. So I'm not sure we currently have a way to look at that, at least in the lab.
Thanks, Mei-Lin. In our experience, in your hands, how likely is it that we submit a patient for biopsy with a highly positive anti-GBM titer and a very fitting history who turns out not to have anti-GBM disease?
So it does happen. And interestingly, I have a case like that right now with high titer, and on histology, I don't see any proliferation in the glomeruli. I don't see a single crescent. It's fibrocellular, fibrous crescent, no necrotizing lesions. I don't see any red cell cast, nothing to suggest that there's any sort of GN going on, and EM was not helpful. And I've had one case, Mozzie's had one, two.
But that patient didn't have any clinical picture to suggest it was just a high positive anti-GBM.
Yeah, and same for the one I currently have. I don't believe that there's a clinical picture that fits like the RPGN type. So I don't know. I honestly don't know what to do. I don't know. There's a very low false positive rate, especially, I can understand if it's weakly positive, but to have a strong anti-GBM titer. So I don't know if it's not pathologic or what. I'm not sure. And I guess that makes a case for biopsy. Okay, anybody else? Okay, thank you.